Hello. I would like to begin by thanking our panelists and the audience for taking the time to discuss the 340B drug discount program on today's webinar. This is the first in a series of webinars, Hill meetings, and field hearings that ASBM will be conducting on this topic in the coming months. We feel that there is a need and a sense for reform, and we're looking forward to playing a part in that happening in the upcoming year. I would like to kick things off, though, with a short video from one of ASBM's founding members, the Autoimmune Association, to set the stage for today's discussion. And after the video, we will bring on the panelists.
You know how expensive prescriptions can be. Thankfully, there's a federal program that helps reduce prescription costs, the 340B Drug Discount Program. The 340B Drug Program lets certain clinics and hospitals buy medications at a big discount, sometimes up to 50%. This helps them save money, which they can use to care for more patients. Thanks to these savings, clinics can offer services to people with or without insurance and make the most of their limited resources. But not all 340B sites play fair. Some have found ways to use 340B to increase profits without helping patients. In some cases, hospitals are setting up specialty pharmacies in lower-income neighborhoods to increase their 340B savings. But instead of using those funds to support those communities, they're putting the money toward upgrading hospitals in wealthier areas. On top of that, some pharmacy benefit managers and insurance companies are keeping the discounts that's meant to help the patients. You deserve transparency, accountability, and access. That is why your voice matters. Ask Congress to protect 340B discounts for patients, not executives. The 340B program was meant to lift up patients, not profits. Let's make sure it stays that way.
Again, I want to thank you for joining us today to hear about the 340B drug discount program. Just as a reminder for those that are participating, if you have any questions during the presentation, please submit the questions through the chat function. We will hold all questions until the end when we have a Q&A and after the panel discussion. Just by way of introduction, I'm Michael Riley. I'm the Executive Director of the Alliance for Safe Biologic Medicines. I have been in that position since we were formed in 2010. And prior to that, I served for 6 years in the Office of the Secretary at the U.S. Department of Health and Human Services, where I was fortunate to be during the passage of the Part D program. Nearly 22 years ago today, actually on December 8th, 2003, we were at Dar Constitution Hall for where President Bush signed into law Part D. And while Part D is the largest drug program in the federal government, which is not surprising, 340B is the second largest, and that is somewhat surprising. I want to welcome on an extraordinary panel that I'm really pleased to have with us today. And I'm going to just introduce each of them with a few comments and then let them introduce themselves following that. Panel, can you come on camera? There we are. I'm going to start with Thomas Barker, who I had the privilege of working 6 years at the department with and who was there at Dar Constitution Hall for the signing. Part D. I tell people that there is no one that I think knows more about CMS and HHS than Thomas, and I'm really pleased to have him here. And in a moment, they'll each do their own introductions. Pivoting to Dr. Feldman, who was the chair of ASBM for 4 years, and who I have learned over more than 9 years now working with her that she has expertise in so many areas that the more you talk to her, the more you realize, and 340B is certainly one that she is well versed on. Kathy, I actually saw present about 2 months ago and chased her down afterwards after her presentation because it was so impressive and asked her if she would participate. And we're thankful that she is here with us today. And finally, Andy Spiegel, who is a founding member of ASBM with me 15 years ago. And his experience representing the patient community, there is no one in Washington that I would rather have presenting the patient's interest than Andy. So we're pleased to have Andy here as well. And with that, Thomas, I'll turn it over for you to introduce yourself.
Thanks, Michael, and good morning, everyone. My name is Tom Barker. I'm a partner at the law firm of Foley Hoag, based in Washington, D.C. I've been at Foley for 16 years. I'm part of the healthcare department here. My practice focuses on CMS, Medicare, Medicaid, regulatory payment coverage coding matters for life sciences companies, and I appreciate the opportunity to be here. As Michael said, we served together at HHS in the George W. Bush administration. I was the acting general counsel of HHS, and before that was chief legal officer of CMS. And really happy to be here today and look forward to participating on the panel.
Dr. Feldman? I think you're on mute.
Hi, I'm Dr. Maddie. I used to have a radio show called Driving with Dr. Maddie. I am very happy to be representing the Coalition of State Rheumatology Organizations, of which I am the Vice President of Advocacy and Government Affairs. I am past president. It is an organization of organizations. Over 40 state rheumatology organizations are our members. And our mission is excellence in rheumatologic care. And advocacy plays a very important part in that. And as Michael said, I would say I'm versed in a number of issues, whether they're legislative, regulatory, keeping private practices open, and 340B plays an important part in a lot of those. And I'm very happy to be here to discuss our point of view.
Kathy?
Yeah. Good morning, everyone. I'm Kathy Oob, CEO of Pontchartrain Cancer Center in Louisiana. I'm also a board member of the Community Oncology Alliance and co-chair their drug policy committee. And lastly, I'm the associate editor of Evidence-Based Oncology. It's great to be with you all today.
Thanks, Kathy. And Andy, last but not least.
I don't know about that. Hey, everybody, I'm Andrew Spiegel. I essentially wear three hats. The main hat is that I'm the CEO and co-founder of the Global Colon Cancer Association. I've had 26 years of patient advocacy in the colorectal cancer world, and I now lead a great organization, which is the umbrella organization for all colorectal cancer patient groups worldwide. My second hat is as the board chair of the World Patients Alliance, and we are the largest umbrella organization of patient organizations working across all diseases. We have more than 750 members from roughly 150 countries now. And I'm the chair of that organization. But as Michael mentioned, for 15 years, I've been on the steering committee and a co-founder of the Alliance for Safe Biologic Medicines. And I've worked side by side with Michael and his team and ASBM to ensure that patients remain at the center of policy discussions, including biologic medicines, biosimilar medicines. We're involved on a number of issues on the Hill right now with MFN and with, and of course now 340B. So great to be with everybody, and thanks for inviting me, Michael.
Thanks for coming, Andy. On that note, I'm going to turn it over to Thomas Barker to kind of set the stage for the conversation with regards to 340B.
Thanks, Michael. Yeah, I thought I'd maybe start off our discussion today by giving a little bit of a history of the 340B program over the past 30 or so years since the program, well, actually 33 years since the program was enacted in 1992. I think you can sort of look at the history of the 340B program across what I would call 5 different buckets of time, like significant milestones that have occurred over the past 33 years of the program. I was actually working for the House of Representatives back in the early 1990s, and I've worked as a health lawyer since then. So I have a really distinct memory of what led to the program's enactment and its history over the years. And so, again, the program was enacted in November of 1992. The first President Bush signed the program into law as part of the Veterans Health Care Act of 1992. That law was actually designed to address veterans' healthcare issues that arose after the first Persian Gulf War. And really, drug pricing wasn't even a major concern when the law was enacted. President Bush didn't even reference the law in his signing statement. But Congress included the program because it was concerned that the year prior, when Congress enacted the Medicaid drug rebate program, it caused pharmaceutical manufacturers to reduce, I guess you could say, voluntary discounting arrangements that they had worked out with some providers. They were concerned that those discounting arrangements would trigger the Medicaid best price requirements of the new law. And so the discounting programs went away. And Congress was concerned about that. So they codified the ability of manufacturers to continue providing discounting arrangements to entities like disproportionate share hospitals, community health centers, as a way to avoid triggering Medicaid best price. That's why the program got enacted in the first place back in 1992. Congress was concerned that manufacturers would stop providing discounts to what we now call covered entities because it might trigger best price, and that's why the law was created. So, from 1992 until the early 2000s, the program continued to grow, but there really weren't a lot of significant pushbacks. So, like, for example, in 2005, pediatric hospitals were added as covered entities, and that was done really without a lot of controversy. I felt like in that decade and a half period between 92 and the early 2000s, covered entities and manufacturers had achieved, I guess you could say, some sort of equilibrium. Manufacturers provided the discounts, covered entities accepted them, and there really wasn't a lot of pushback. Also in that period, HRSA, which has limited authority to regulate the program, even though they administer it, but Congress never really gave them a lot of authority to regulate it. HRSA allowed covered entities to dispense drugs through off-campus child sites and also using one contract pharmacy per covered entity. HRSA also in that period proposed a more precise definition of what constitutes a patient under the program. And so all of that happened in that period, late 90s, early 2000s, where again, I feel like there was sort of a sense of equilibrium between manufacturers and covered entities. There were HRSA made some changes to the program that favored covered entities, but that sort of happened without a lot of pushback. But then I think the next significant development in the history of the 340B program was the enactment of the Affordable Care Act in 2010. And as part of the ACA, Congress added additional covered entities to the program. So, for example, cancer hospitals, different categories of rural hospitals. And during that period, we also saw the first litigation under the program. HRSA tried to limit the use of 340B pricing for orphan drugs, and that interpretation by HRSA got challenged in the courts, and pharma prevailed in that litigation. So we saw some litigation in that period. We also saw the program really start to grow. HRSA allowed, for example, covered entities to operate multiple contract pharmacies. And that decision by HRSA led to the start of one of the most significant criticisms under the program: the ability of covered entities to essentially take advantage of the arbitrage between the 340B price of a drug and the Medicare or commercial reimbursement amount for the drug. And that really started the growth of the program. A CBO, just as an example, a CBO report from earlier this year showed spending on drugs in the 340B program was around $50 billion in 2021. It grew to $66.3 billion just 2 years later in 2023. And a report from earlier this week shows that spending on 340B drugs is now over $80 billion. So Michael mentioned in his introduction that 340B is the second largest drug program in the United States after Medicare Part D. And I feel like that growth really started after the enactment of the ACA, both because Congress had expanded the number of covered entities under the ACA. HRSA made a policy decision to allow multiple contract pharmacies, and also HRSA was really attempted to, through policy changes such as the use of child sites, really try to expand the program. So I feel like I guess you could say the increasing acrimony between covered entities and manufacturers, that really continued over the next decade and a half, from 2010 to really the present day. So during this era where there's, I think, more acrimony than there ever was in the early years of the program, so manufacturers started to push back. They said, no, you know what, we're not going to honor multiple contract pharmacies. They asserted that HRSA never really had the authority to issue binding guidance under the program in the first place. And so they started to push back. They filed litigation. They would take the position in negotiations with covered entities that were only going to allow one contract pharmacy. And there's been litigation challenging that position. Covered entities filed litigation challenging manufacturer attempts to limit contract pharmacies, and in some cases, multiple child sites. Congress held hearings. The Government Accountability Office and the HHS Inspector General issued critical reports of the program. So I feel like that's like my next bucket in time, that period from, say, the enactment of the ACA really up until the present day. I feel like there is significantly more pushback on the part of covered entities than ever existed in the earlier years of the program. And so that brings us up to today. On November 14th, so a month ago or so, HRSA, actually just about a month ago, HRSA announced the implementation of a new program model that allows the 340B program to be operated using an after-the-fact rebate model. So the way 340B works right now is that manufacturers provide an upfront discount to covered entities, and covered entities are allowed to purchase the drugs at the discount, which is, to make it relatively simple, it's the Medicaid best price. Covered entities are allowed to purchase drugs at the Medicaid best price for the drug. And then manufacturers are required to provide that discount up front. Under the new HRSA model that got announced on November 14th, manufacturers are able to participate in a rebate model where the discount is not provided up front. Rather, it's provided via a rebate after the purchase of the drug. So the covered entity has to purchase the drug at the market price, essentially, and then petition the manufacturer for the discount up front. This model only applies to drugs that are chosen for price negotiation or price controls under the so-called Inflation Reduction Act. So that really only applies to 10 drugs currently, but of course that number will increase as the number of drugs subject to price controls under the IRA continues to increase. So as you might anticipate, the rebate model that HRSA announced has been relatively controversial from the perspective of covered entities. Last week, the American Hospital Association filed a lawsuit in federal district court in Maine challenging the HRSA rebate model. So it's now the subject of litigation. We'll see how that plays out in the federal courts, but as and I'm sure HRSA anticipated. The rebate model is controversial, and it has now led to litigation. I think as our program goes on today, we'll talk more about potential suggestions to reform the 340B program. I won't go into those now, but I do know that there are several ideas that are being kicked around to potentially reform the program and address the rising costs of the program. So we can talk about that as the program goes on. Michael, I finished up a little bit earlier than I planned, but I think this is good because I think I'll turn the program now over to Dr. Feldman, and that might potentially give us more opportunity for questions. But again, just to sum up my presentation, I feel like you can sort of look back at 5 different eras of the 340B program: the initial enactment, the period of equilibrium, I guess, between covered entities and manufacturers, the enactment of the ACA, now the increasing acrimony between covered entities and manufacturers, and now we have the new rebate model, that brand new rebate model, subject of litigation. We'll see how that plays out. So maybe I'll stop there, and maybe Dr. Feldman, I'll turn it over to you now.
Yeah, you're still on mute, Dr. Feldman.
Thank you, Tom. That was a great summary. I really like that period of equilibrium. Yeah, not so much anymore, as you said. So, why is a rheumatologist in private practice interested in 340B? I can tell you most physicians have not. I'll use the term 340B, and still it just kind of is like this. It's 3 numbers and a letter. But one of our missions, as I had stated, is excellence in rheumatologic care. And, whether it's deep pockets on the pharma side or deep pockets on the hospital side, I don't really care. What I care about is that the population that this particular program is supposed to help, that they get helped. And certainly those initial grantees, the federally qualified healthcare centers, Ryan White, the rural hospitals that really need this are doing a very good job with, stretched federal resources, and that's where it's supposed to be. But I'm going to just start with a couple of stories, because these are stories that I heard that actually prompted me to, mention to CSRO, this is actually an issue that we need to get a hold of, because our patients are being affected. Medicaid is being affected, employers are being affected, and certainly physicians in private practice are being affected. But let me just tell you this little story. As a rheumatologist, we do training, fellowship, and 2 of my younger partners had trained at a disproportionate share hospital, very large disproportionate share hospital here in New Orleans. And they had admitted a sick, young African-American female lupus patient with Medicaid to their service. And when they discharged her, they needed to bring her back in a month for follow-up care. And the administration of this disproportionate share hospital that gets 340B said, no, you can't bring her back. She's Medicaid. We have reached our 11.75% disproportionate share of inpatient Medicare and Medicaid patients, and you can't bring her back. And they said, what are we supposed to do? And the administration said, send her to LSU. And they said, well, LSU has a 6-month wait for a rheumatology clinic. And the administration said, tough. And this happened not once, but over several years, both of my younger partners. And then this is not something old. I just heard that last month there was a sick lupus patient on a drug called Cytoxan that was being infused at this particular 340B entity, and was just booted over to the United Medical Center, the LSU program, and no warning, just said, we're not infusing this patient anymore. She was Medicaid, young African American. So the point of this program is to help, uninsured, underinsured, and vulnerable populations. And I can tell you in South Louisiana, young African American women with lupus isn't underserved. So right here, this was enough for me to get involved and learn more about 340B. And the more I learned, the more I realized that not only are the intended patients not getting the care they need, Medicaid is in our state and in the government is actually losing those rebates, because when the 340B rebate is taken, the rebate that would normally go back to the state for the drug is not there. So we're talking, I guess it's somewhere around $6.5 billion in lost Medicaid rebates. And right now we're talking that Medicaid is perhaps underfunded and the states are going to have problems, and this just exacerbates that. And then finally, because of the consolidation, and I'm going to let Kathy talk about that a little bit more, because these hospitals make so much money on 340B, when young specialists come out, particularly the ones that use expensive medications, a huge carrot, because of the profits of the 340B, they can hire all of these docs that infuse and prescribe very expensive medications and just make more money. This one particular entity, after just recently refusing a Medicaid patient a couple years ago, bought a huge shopping center in one of the most affluent parts of New Orleans. So I think there's some oversight that's needed, and it's not who gets the money as far as I'm concerned. And as far as I think, practicing physicians are concerned, we want the patients who deserve to get care and to have oversight. So because of this consolidation, independent private practices, which have been shown to be the lowest cost of care site, patients are now being siphoned to these higher disproportionate share hospitals. And a number of the employer groups, the National Health Purchasers Organizations, have found that employers are now noticing that they've lost access to the lowest cost of care sites. So there's a number of areas that 340B is harming. Number one, the patients it's supposed to serve. Number two, Medicaid programs, both state and federal. Number three, employers. And then finally, independent physicians. And because of that, that's why I've gotten involved and have brought CSRO into it. Now I'll turn it over to Kathy to talk a little bit more about her issues.
Well, my issues could take the next hour, Maddie, but I'll go as fast as I can. Whoops. All right, so I'd like to, use my time with you all today to provide a brief overview of what Dr. Feldman, myself, and many others like us who are involved in this space see on a national scale. And then I'd like to pare down to see what I see in our local market. So, for a lot of observers, the 340B debate often seems like it's between big pharma and the hospitals. But, the real issue isn't about ending the program. It is a beautiful program in its original intent, but it's about fixing it so, patients actually benefit. And right now, they often don't. And so, many of us know, the New York Times article several years ago that talked about Bon Secours. And so Bon Secours acquired Richmond Community Hospital several years ago and basically leveraged its 340B status while, heavily reducing resources in patient care at Richmond Community, which, Richmond Community was started in 1907 by, 5 Black physicians to serve their area. And it was a teaching hospital and cared for all of, the patients within that area because access to care for them was impacted by lack of public transportation and such. So Bon Secours acquired Richmond Community, several years ago. And what it did over time is, it stripped Richmond Community of most of its specialists. They left. And many of its resources. And moved those resources into wealthier zip codes. So, once what was a thriving full-service community hospital, Richmond Community now operates more like a glorified ER, after the ICU and most of their specialty services were cut. And, the net impact in that is many patients in that Richmond area have lost access to care. And, all during that time, while Bon Secours was moving those services, They also never saw cost relief, which was kind of the intent of the program in providing, greater access to under and uninsured patients. And one of the things that Michael heard me speak about when we met was my bigger argument is if you look hard enough, there's a Bon Secours story in most states across the country and probably in multiple areas in given states. So, for example, one of the practices that we have at Pontchartrain Cancer Center is about an hour north of any of our other locations. Now, there is a 340B entity in that market. However, it does not have oncology and it does not have infusion services. And for the record, there's not a lot of public transportation in the state of Louisiana. Maybe in New Orleans, but certainly not in any of the markets with which we have practices. So, we're the only oncologist up there for all of those patients. And to give you guys an example, if we were to close, the hospital is not prepared to absorb those patients because they don't have oncology and they don't have infusion. And as I mentioned, we're an hour away in any direction from the next site of care, which is quite frankly us or a 340B entity. However, it's also worth mentioning that, it is 52% Medicare fee for service, but the rest of it is either Medicaid or managed Medicare. And, we talk to our patients about these things. And, a lot of cancer patients rely on caregivers and loved ones to drive them to and from their appointments. And there's a great concern for us that if we were to close, then, these patients, a decent percentage of them would lose access to care. And that is not, as a broader statement, that's not the way healthcare should be functioning in the United States. So, I'd also like to, take a second and mention another way that 340B entities are, quite frankly, seeking to secure their current business model. So there is a growing trend amongst some 340B hospitals that are amending their bylaws to not grant hospital privileges to non-hospital employed physicians. We are experiencing that in our own market, which restricts our ability to grow and serve more patients in our areas. Because as a medical practice, now if we hire another physician, our largest 340B entity will not grant them hospital privileges. So they would not even be able to care for their own patients in the hospital that is closest for that given patient. And yes, we are seeing this bubble up across the country. The most famous example is in Philly, where Alliance Cancer Specialists is alleging that Jefferson Health is restricting access to their 36 physicians, again, by amending hospital privileges. And in talking with some of my colleagues at COA, these two stories are not isolated. They're just not making the news as much as perhaps, the Alliance story did. But we're also seeing an uptick in 340B entities referring out certain patients due to cost. And this is something Dr. Feldman brought up earlier. For example, within the last month, we recently received a referral for a dual eligible, so Medicare, Medicaid patient who needed expensive immunotherapy to treat her cancer. But she was referred to us because she could not afford the cash price offered to her by the 340B hospital. Now, I want to stop for a minute because it is very worth mentioning that it is a violation of Medicaid guidelines. And Tom, Michael, correct me if I'm wrong, but it's a violation of Medicaid guidelines to bill a patient for a covered service, of which this particular drug and its administration charges are covered services. And so we thought that was kind of interesting that the 340B entity referred her to us, but they're the 340B entity who's, again, the intent of caring for the under and uninsured. We thought that was kind of interesting. But then, I want to take, my few remaining moments to talk with you guys about what we also see kind of more on a national scale. Because 340B is not just about hospitals, and it's, not just about patients. It also has the ability to impact state budgets and, certain, state health plans. So in 2024, the North Carolina State Treasurer looked at how 340B was impacting North Carolina. And what they found was that, 340B entities were billing the state health plan about 5 times more for their discounted acquisition costs for oncology drugs, generating thousands of dollars in profit per claim. And in some cases, they found that the hospital charged 12 times the cost. Meanwhile, the non-340B entities billed significantly less. And so, the trickle-down impact of that means that, state employees, taxpayers, and patients all across North Carolina were overpaying while hospitals profited on that spread. And I thought, Dale Falwell, who's the treasurer there, I thought his, he did a blunt conclusion tag at the bottom. And, it very clearly said that in their opinion, 340B savings are not being used as intended, and transparency is urgently needed. And they are trying to move towards that, at least within the state. But, again, these things, just like I said, Richmond, you could probably find Bon Secours stories everywhere. If most states probably looked at the impact of their, the 340B on their state and their health plan, they might draw very similar conclusions. And of course, there's just, and I think we're going to talk about this at the end with the Health Committee's 340B report. But, over the last few years, the reports just keep coming and coming. North Carolina, we talked about Richmond. And then, just this year, the CBO report showing that the program has ballooned from 6.6 billion in 2010 to now $43.9 billion in 2021 in drug purchases, largely driven by hospitals adding those off-site or child site clinics. And yet, the CBO also mentioned that they could find no direct evidence of patients benefiting through these lower out-of-pocket costs. And the impact on community oncology is real. As I mentioned to you all earlier, we are now facing, as a business entity, restrictions if we hire new physicians. And, independent practices are not allowed to participate in this program, which creates that very uneven playing field that is often, fueling consolidation. And I think I have like 1 or 2 minutes left. But again, to show you that microcosm back into Louisiana, when we started Pontchartrain Cancer Center back in 2020, there were, I think, 20, community-based medical oncologists across the state. Now there are less than 5. And, the rest of those physicians didn't all retire, but they are now absorbed into the hospital systems, super groups, and some did retire. So, with my last 1 minute left, and I am watching the clock, Michael, I do want to, just, reiterate that, the 340B mission, it is a sound program in its original intent, but without guardrails, transparency, and accountability, This program has ultimately distorted care and patients are being left behind. So thank you for that, Michael. I'll stop now.
I
Thank you,
wanted
Ken.
to add one thing to
Go ahead.
what Kathy said. She was talking about the different states. So not only just in the increased cost of care, but as I had mentioned, in terms of foregone rebates, Pennsylvania lost about 270 million, Illinois 240, Massachusetts almost 200 million. So you put that on top of the costs. And then I have, testified in a number of states when they were trying to expand the program. And I can tell you what happens and what the state legislators see is they only see the rural hospitals that are doing the right thing and the federally qualified health centers, the initial grantees, the Ryan White clinics. They never bring out before the insurance committee or the committee of jurisdiction those that actually need the oversight. So I think there's blinders being put on some of these state legislators in terms of what's actually going on. And with that, I will give remainder of my time to Mr. Riley.
Thanks, Dr. Feldman. It's funny that you say that because one of the questions I had teed up just from watching Senator Cassidy, I'll read you the question and it follows exactly what you just said, but I want to use it as an opening discussion with the panel. And it is, do you believe, as Senator Cassidy recently suggested, that those against 340B reforms cherry pick good actors in order to put on a positive face for the program? And that's exactly what you're saying. And that was his point, that basically whenever, and if you go on YouTube, put in 340B, and you will get video after video after video of talking about the program, its original intent, how it doesn't cost taxpayers anything, and how it must be expanded. And you say, in what universe are we living in? And it is to that point you just made, which is no one seems to bring out the bad actors. And even in the hearing where they had Ms. Siegel in recently with Cassidy, and he said, you put on a good face and you may be doing great work, but you are not the problem. And we all need to agree that this is not the problem we're talking about. So how do we get the program? Basically, the expansion is a demonstration of the fact that everybody's figuring out a way to game it. And that really is the problem. And I want to just kind of throw that up to you, Dr. Feldman, and to the panel to kind of kick this conversation off, because I think this is a big part of the problem.
I mean, when you look at the tens of thousands of covered entities now, and Tom can probably give us the exact number that are out there, HRSA has the ability to do 200 audits a year. So it is a drop in the bucket. And if they do find discrepancies, it's up to the covered entity to correct them. And there is no oversight to see if they've even corrected them. So I think, and so for example, and I'll give you an example of a really good one. One of my younger partners, his wife is a family physician at one of the covered, community care centers. And it's a clinic. They turn no one away. And the patients get the drugs at pennies that are extremely expensive. You would think that when they see Medicaid patients, they would have, an easy in, particularly to this other 340B entity, but they don't. So there are good actors out there, but they're often stymied in terms of their ability to give good care by those disproportionate share hospitals that are not giving good care. And Tom, you may want to expound on exactly how many covered entities are out there now.
I'm not sure off the top of my head. I'm not sure how many there are, but it's exploded since 2010, and it's because it's a combination of, number one, the expansion of covered entities themselves, cancer hospitals, pediatric hospitals, and in my opinion, different classes of rural hospitals. That has been a large expansion, but then also HRSA made a policy decision in 2010 or 2011 to allow covered entities to have multiple contract pharmacies. And I think it's a combination of the ACA expansion of the hospitals, number of hospitals themselves, and the number of contract pharmacies. And that's where the the growth, you've really seen the explosion since 2010.
It's more than, by the way, more than 60,000
I was
is
going
the
to say
number.
40,000 would have been my
More than
guess.
60.
60.
So from 8 to 60.
And,
So
and not to mention, some of those covered, people know me for my PBM talks and presentations. Some of those covered contract pharmacies are the large three PBMs who are all in the Fortune 15. These are for-profit companies that are making money on 340B pricing. And I have a lot of patients that go to the specialty pharmacies of these particular PBMs that are part of the 340B program. And oftentimes they can't afford the medicine. Are they ever offered a lower price because that particular entity has 340B profits? Never. I've never seen it.
well, and I think, you and Kathy both hit on something, you with the lupus patient in particular, which is, and when you told me that, I said, if I was still at HHS, that'd be an investigation. I mean, the idea that someone uses the disproportionate share percentage as a ceiling to basically say sorry, and that is how they're making a lot of money as well, which is basically get rid of the patient that you're supposed to be serving with the discount and bring in someone who's insured and basically, or who's paying a copay or whatever it may be, and that's how you increase your spread. And that's what most of these places are doing. That's where the numbers and the growth are. But I almost find it unbelievable, Thomas. I would be interested in your thoughts on it. Just the idea that a hospital would basically say, no, we're at the 11.75, sorry, send her on to somewhere else, even after saying this is going to be 6 months before she gets treatment. Too bad. I mean, that to me is that's an investigation from when we were in the department.
I also think another issue that is relevant here is the effect on patient cost sharing. So let's say you have a Medicare beneficiary who comes to a 340B covered entity hospital for administration of a cancer drug that's paid under Medicare Part B. There's also a 20% copay. So if the hospital is able to purchase the drug at a discount, the copay is still calculated off of the Medicare reimbursement amount. And so there is a significant delta between what the hospital acquisition cost is and the beneficiary copay. And that's another issue that I think CMS tried to address this in the first Trump administration by changing the reimbursement model for drugs that are paid for in the outpatient setting. But that payment policy was invalidated in the courts, and so it's no longer in effect.
And the Medicare Advantage patients are the same thing. The cost share that Medicare Advantage gives their I call it quote unquote beneficiaries is based on the reimbursement, the higher price, not the low price. So these I mean, their cost share 20%. We have patients now, we're talking with ophthalmologists, we're talking across. This has turned into a big problem. There's the cap on Part D. There's no cap on Part B, and some of those, and a lot of them are dispensed and infused and provider administered at these disproportionate share hospitals, and patients are just losing access to care, period.
And something we didn't talk about, and Michael, and have an opportunity to touch on, was percentage of medical debt, because we are seeing that as well. We've inherited a few patients from the hospitals who were, underinsured, but now they're in medical debt to the 340B entity. And, we're seeing it, it's a growing trend. And, that was something that Falwell also found in the North Carolina Treasurer's report, was that their state had a very high percentage of medical debt from those 340B entities.
Yeah, and you also mentioned, Kathy, the idea within the oncology space, and I think from Andy's perspective as well on the patient side. I mean, if you read reports on some of the hardest hit, it's in cancer, right? First of all, for a number of reasons, including the high cost of cancer drugs. But one of the things they say is happening is the migration of care in cancer patients. You actually give an example of where there's almost no migration because you have nowhere to migrate to. And that's an even bigger problem. But let alone basically changing a situation where someone's in the middle of cancer treatment, stage 3 or stage 4, whatever, and all of a sudden they have to find another place to go because of the program. And the other piece to it is what you said, and Dr. Feldman hinted at too, which is hiring away basically folks from your center to put in a big 340B hospital because they make more money on cancer drugs than anything else, so they want to build up their in-house oncology practice.
Yeah, there was an old study back in 2014 that the average, 340B entity brings in about $1 million a year in profit for every medical oncologist that they employ.
Wow. Well, I want to be mindful of time, and I certainly want to get to the conversation as we talk about all the negatives to the positives and move away from Thomas's world of acrimony to agreement. I think, this is one of those areas where in this incredibly partisan environment, which when Tom and I were doing Part D, I thought that was partisan. That is nothing compared to where we are today. But I do think with the Gang of Six and with generally Senator Cassidy leading the way on this, that there is definitely more in favor of reform than those who are out saying if we do anything, we need to strengthen the program, which, by the way, means expand the program in the same negative way that it's been expanding. And so, Thomas, I guess I'll start with you and just kind of open it up to the panel to talk about, whether you have optimism that after Cassidy's report came out and the work that he's been doing, and many have said that's a blueprint in a number of areas for reform, that we actually can get something done as soon as 26.
Well, one area where I think there might actually be agreement between covered entities and manufacturers on an area to reform 340B is to give HRSA greater regulatory authority. I mentioned in my presentation that the courts have concluded that HRSA has very limited authority to regulate the 340B program. And I feel like if Congress were to just say, yes, HRSA, you have authority to regulate the program, just like CMS has authority to regulate hospitals and HRSA has authority to regulate the organ transplant system in the United States, give HRSA the authority to regulate the 340B program. Other areas of reform obviously would be more controversial, but some issues that are discussed are a statutory cap on the number of contract pharmacies, limiting the use of child sites, greater transparency as to the use of, I mentioned in my presentation, the arbitrage between the 340B covered entity price and the reimbursement amount, greater transparency on what those funds are used for. Those are all areas that I think have been addressed as potential topics for reform by Senator Cassidy, and also in the House on the House side in the Energy and Commerce Committee. I think they'd be more controversial, but those are also potential areas for reform as well.
Well, one thing I would be curious about, though, because when you talk about the opportunity and more authority to regulate, you have to have the resources in order to do the regulating. You have to have the ability to provide oversight and do more than a few hundred audits per year. And so there has been obviously conversation about moving the program out of HRSA, for example. Where do you see that in terms of controversy?
I was just going to mention that also. There was certainly talk earlier this year as part of the DOGE efforts to restructure some of HRSA's functions and move their programs over to other components of HHS. And there had been some talk of moving the 340B program over to CMS, which I think sort of makes sense because CMS obviously regulates the Medicaid drug rebate program, right? And there is a clear link between the Medicaid drug rebate program and 340B. And so potentially moving 340B over to CMS because the expertise already resides at CMS, that is a potential area for reform as well.
Yeah, I mean, I think I think just one more thing, and I think that in terms of looking at HRSA's capability and looking at CMS's, what you're talking about at HRSA is in a way hiring more people and training more people to do something they're not as naturally prone to do versus moving it into CMS and just beefing up there if you need to. But you certainly can go from a few hundred audits up from, north of that, which is a big part of it. There's how are you auditing all of these bad actors, 60,000 covered entities, a few hundred audits? That's not going to get it done, right? And then secondly is, as Dr. Feldman said, you got self-correcting where you're basically asking them to solve the problems. And I think that mentality would change. In some respects, I look at HHS and think of the IG and how aggressive they are with regards to pharmaceutical companies and correcting issues when they make agreements with them for, settlements or whatever. And I think there needs to be a much more aggressive mentality with regards to hospitals, because ultimately, if you start being more punitive on some of the bad actors, you're going to cut it down, not out, but you will definitely cut it down.
That was one of the things I was going to say. So many of our pieces of legislation, which are great. First off, there's no oversight to see if there are transgressions, and secondly, the teeth are just so blunted that so much money is made on this program that depending on what the fine is. I mean, when we start looking at some of the False Claims Act fines, that then you start talking about some real money, and if the hospitals were in some way threatened. And the ability to use 11.75% disproportionate inpatient Medicare, Medicaid as a defining amount to qualify you as a 340B. I think there needs to be, once they get more codification of the actual intent of the program, then perhaps setting a boundary or a parameter that actually measures how much care you're giving to a sick young Black female lupus patient with Medicaid. That should never happen. And if there were more stringent guardrails and someone making sure that those guardrails aren't transgressed, I think it would go a long way to actually helping and as well as the medical debt. How can somebody be in medical debt from a hospital that gets money in order to take care of people who can't afford their care?
Yes.
And they're sued.
Great question.
They're oftentimes sued. That just sort of seems, you shouldn't be able to sue a patient because they can't pay you if you're getting 340B.
Yeah. Well, and I think, one thing I worked quite a bit on when I was in the department was DME fraud. And I think there's a lot of commonalities between DME fraud and this issue. And we worked specifically on an operation called Whack-A-Mole, which shows what happens when you put out one bad actor, another one pops up. And that is because of the money. And so the more the money has proliferated around the 340B program, the more incentives there are for bad actors to take bigger risks. And in the current situation, the risk isn't even that big. There's not enough oversight. There's not enough, punitive action for bad actors. And therefore, they're just going to kind of keep doing what they're doing, which is why this is only the first of these meetings that we will have in a series, because you could go on, as I can't remember if it was Kathy or you who said we could talk for hours. I think it was Kathy who said we could talk for hours, and that's true. But I know that we only have a minute or so left. So I want to just kind of end on that note by thanking everybody for participating. This is a great conversation that really opens up a discussion, I think, in general. And I mean, as someone who has been involved in a number of different policies that got reformed, I have optimistic hope that something can be done in this area, because I think there is commonality that crosses party lines, which is really important these days with regards to the, and so really a lot of it is, and one thing I saw somewhere is that no matter what effort you are going to do to reform on this program, it requires education. And Dr. Feldman, you said it best. You can talk to doctors that don't even know what this program is. It's, 340B, 3 letters and a number, and that's it. And yet, look at it. I mean, look at the growth, look at the money, and look at the abuse of the program right now. So I'm going to open it up for anybody who wants to add anything at the end. I really want to thank the panelists for participating and giving their time. Kathy wasn't even feeling well, so I really appreciate her rising to the challenge. And Dr. Feldman was dealing with a baby last night, so we appreciate you getting up early and coming on. So with that note, any final thoughts before we go?
Thanks, everyone.
Thank you for having us.
Enjoy being on the panel.
Yep. All right, on
Have
that
a great
note,
weekend.
thanks, Kathy. Appreciate it. On that note, I think that's it. It's 12 o'clock, and I think someone had to jump to another meeting at 12. So on that, thanks everyone. And this was recorded, so we will make it available, and hopefully we will get it out there and put it on LinkedIn and do some other things with it so people have an opportunity to see it.
All right.
Thanks all.
Take care, everyone. Thanks.
Thanks.
Bye.
Bye.
Thank you.